justice to them sometimes. We cannot do justice in terms of a final diagnosis. So here what the faculty has tried to do is to give you a little journey down cytology samples of how, whether routine, non-routine, basic, conventional, liquid-based, ancillary, what all is possible. See, it may not be available at your center, but at least you can guide the clinician that this is it and you can get this done. And the situations in which where there is a difficulty of how to get out of a situation and suggest something, we'll be giving such ideas also. So I hope you enjoy this. I'm Dr. Kirti. I head the Oncopath division at Metropolis after experience in Hinduja, Prince Ali Khan, Gangaram and various such places, basically trained in the armed forces. And I have, Kane madam is going to come and take the thing and introduce the subject, and we'll just start the journey from here.
Hello, good morning everybody. Yeah, I'm really surprised to see so many faces in, pure cytopathology like workshop, because as you know, there are so many parallel workshops. And I would really like to thank the organizers, Aparna Jairam and Suvin Shetty, for having this, CMEs or workshops on different topics. And as far as cytopathology is concerned, I always feel that over last 5 decades, it has expanded its horizons tremendously as compared to what we were taught. But unfortunately, the training in MD pathology level is not in congruence with the growth of the cytopathology. So all of us need to look into it, those who are in teaching or, the students and all. They need to be trained from cytopathology because they feel they are very inadequate. So on that background, these CMEs, really have an importance. And that is what I said, I see more and more cytopathology, topics coming up. Now today, since this is the first cytopathology workshop, we have selected topics which are more problematic for pathologists while reporting. So you can see the first topic is in gynae. We have selected only those atypical ones. Straightforward LCIL and SCIL is easier to diagnose relatively, whereas those ATPRs, so Dr. Bharat Rekhi will elaborate. Then I am also going to dwell mainly on indeterminate types of thyroid efficacy, which is a diagnostic challenge. And maybe next year onwards with organizers, we can have one topic-wise, theme-wise cytopathology workshops. But this is, according to me, is the first workshop only on cytopathology. So the topics are assorted. As she said, it will give you general overview of what all is there in cytopathology and what is the future of cytopathology. So I hope all of you would enjoy this. And let's keep it as informal level. At the end of this, whatever questions you have, you can ask. We have kept some time for question and answer. Don't hesitate to ask the questions. Thank you. Now I call upon Bharat Rekhi for his talk on gynae.
Good morning, everybody. I'd like to thank the organizers and Dr. Kane and Dr. Kirti for giving me an opportunity to present in this very important workshop in Pap smears. And the introductions you've heard from Dr. Kane is all set, the floor is all set, and I'm going to speak on the atypical cells that we come across, which we find a bit problematic. So I took this part, including what is atypical cells and including my perspective and how we deal with it, how much we find challenging and how do we deal with it. Can I have a pointer, please?
I would just like to introduce him. He's a professor of pathology at Tata Memorial Hospital with special interest in gynae, bone and soft tissue, and special interest in gynae cytology.
Can we have a presentation? So I'll be dealing with the significance and evaluation of atypical cells in Pap smears. Okay, the atypical squamous cells became infamous. Why? There's a little intellectual aspect to it. It's a reflection of inherent tension among the cytologists not to be able to make this black and white decision about positive or negative. And that's a reflection in the treating clinicians whose managements are quite dichotomous, is to treat or not to treat. So that's our difficulty, and that's the treating clinicians. So this is why this entity becomes infamous. Okay, so why did it become infamous? Just a little background towards, I think everybody is abreast with the TBA system, how it evolved initially from the 1988 to the 2001 classification system. ASCUS was annually reported in 2.5 million PAP tests in the United States. Some time ago when it was evolving, from the 1988 to 2001 classification of the TBA system. And the permissible reporting frequency of ASCUS is less than 5%. And what happened, the reality was, in 1996, 768 labs, a survey showed that ASCUS was about 5.2%. And ASCUS, I mean, is atypical squamous cells of undetermined significance, is what we call that. So that led to the Bethesda system to make it more classified in terms of the atypical squamous cells. And the first one is the atypical squamous cells of undetermined significance when you can't rule out L-cell or the low-grade squamous intraepithelial lesion. And the second is atypical squamous cells cannot exclude HSIL or the high-grade squamous intraepithelial lesion. These are the terminologies that we use on cytology, the L-cell and H-cell, and I'm sure everybody's abreast with these terms. So what is ASCUS? As much as it seems to be a indeterminate or undetermined entity, it's a bit defined to make it more easier for us to understand and deal with it. So cytological changes suggestive of cell which are qualitatively or quantitatively insufficient for a definite interpretation. So we're dealing with a cell or cells which in terms of their numbers are less to call an L-cell, or they don't look morphologically as much as L-cell, is what is an ASCUS. And the criteria are the cell is of squamous differentiation, is of the intermediate cell, has high NC ratio in terms of the enlarged nucleus, and there is minimal nuclear atypical features. When I say minimal nuclear atypical features, I would like to emphasize we should be looking at the nuclear borders. Is it thickened, irregular, chromatin clumping, is it homogeneous, mild variations? So these all features should be minimal in a entity that is the ASCUS. And then we also include atypical parakeratotic cells as a part of the ASCUS terminology, or the cells. So this is an example, as I was told one time, that it's very difficult to actually show what an ASCUS cell is from one of my colleagues in All India Institute. He said, I don't know how to show actually an ASCUS cell. And this is exactly in real time. You see a cell like this is a superficial, intermediate, and this is an ASCUS cell. It's a simple increase in the nuclear size. You see minimal increase in the chromatin, but you don't see very thickened nuclear membrane borders, or you don't see clumped or hyperchromatic nucleus. And this is a single cell, so we call this as ASCUS, or atypical squamous cell of undetermined significance. That's another example of ASCUS when you're very tempted to call as an L-cell because you're thinking that this could perhaps represent a coilocytic atypia. But you look at the chromatin pattern. I always emphasize in cytology, we look at the chromatin pattern, that should be very dense, coarse chromatin, irregular, thickened nuclear membrane. And if you draw a quadrant in 4 corners, the chromatin should be very heterogeneous. And then, like I said, parakeratotic cells, you see little keratinization more happening and binucleation also. So this only occasional cell like this gives you a feeling that should I call it L-cell, but that's not enough to call an L-cell. This is an ASCUS. In contrast, you will see this is what an L-cell is. Now, I think you can appreciate that, again, this is the superficial, the comparison is the intermediate cell, and here the nucleus chromatin is highly hyperchromatic. So you can just compare to the previous cell, the nuclear chromatin here, and here it's so dense. And the space is quite edged out, the halo or the space is quite edged out, and coilocytic atypia is equated to an L cell, and this is an L cell. Okay. So a little bit of quiz. I came across this case in which a single cell looked like this, and you see, the nucleus is enlarged, there is chromatin is increased, there is clumping of chromatin in the single cell. In the background of these little inflammatory cells and these superficial cells. So anybody would like to think what this cell would you like to report as if you're seeing it as a single cell? And with the little background that I shared with you. But you would at least think that this could be an ASCUS, right? But you look at the chromatin is a little more denser. And that's what it came on histopathology as CIN1. You can see this throughout this atypia in the cells, and the chromatin is dense and very edged out nucleates. Comes mostly in the superficial to intermediate layers of the ectocervical tissue, the CIN1. All right. So now we come to as sketch. That is, atypical squamous cells cannot exclude HSIL or high-grade squamous intraepithelial lesion. Now these are generally sparse cells when they come, and the criteria again a bit defined when we're looking at something gray and not being able to classify it. These occur singly or in small fragments, less than 10 cells, maybe in a stream of mucus. So these can come in a tandems, cells in a mucus stream. And the size is of a metaplastic cell. So you saw the ascus cell is of the size of an intermediate squamous cell. This is of the metaplastic cell type. And in fact, these were actually the HSIL or the ascech cells were metaplastic dysplasias, not to confuse you, but just to tell you that this cell of the size of interest is metaplastic cell, and the cell would be 1.5 to 2.5 times the normal cell. NC ratios and nuclear features approximate the HSIL. So here you're dealing with a cell of a metaplastic squamous cell type. You don't see it enough in terms of its number, the cells that you can call it HSIL, so you can restrict to the entity called ascech here. Okay, so this is what an ascech would be. Your cell type, you can see the intermediate cells, and this is a cell of interest. This is a single cell. It gives you could be a atrophy kind of cell, but the chromatin is more denser, and you can see another cell in the same case with a denser chromatin, and you can call this as an ascech. This is an HSIL. When you have enough cells which look atypical and are of the size of the metaplastic cells, you can see the chromatin is so dense throughout, high NC ratios, and this is an HSIL, in contrast to the less number of similar cells which are called as ascech. And this is what this particular case of HSIL was. It was CIN2 when you see the till the middle 2/3 of the dysplastic squamous epithelium in the ectocervix, you call it as CIN2, and when it's full thickness, you call it as CIN3. Okay, something which came a little more with a study from Dr. Vinod Shidam, I mean, this is our case actually, was the twilight lesion, something even in the middle, when you're having an ascus, when you're having an ascech, and there's something middle. This was a compulsion or the intrinsic ability of a cytopathologist to offer as much as possible. So here we have an L-cell cell, very clearly edged out coilocytic atypia, and then there is the single cell lurking, which is of high NC ratio, the metaplastic cell type and dense chromatin. So this is L-cell is definite, something indeterminate is ascech. So it's just a convenience. When you would report this perhaps as the higher side, we always report, we'll call it as ascech. But there is something definite that we are having here. So it's a way to say that as much as possible what I'm seeing. And these are the twilight lesions that Dr. Shidam started to call these as. And this is one of the real case scenario that I came across. There was definitely this L-cell cell. So you can see this coilocytic atypia, raisinoid nucleus with this dense chromatin, ridge of the chromatin, and you can see this thickened nuclear border and clump chromatin. This is clearly an LSIL we have here. And this is something which is lurking here as a more dysplastic, higher grade cell, and that's only single. So when you're dealing with very less number of such cells, you call them as ascech. And the overall entity becomes L-cell plus ascech. So L-cell H is the twilight lesions, if you believe in this. Otherwise, you can say that this is ascech because you report always the higher side, okay? And this is what this lesion on biopsy turned out to be. It was CIN3 with HPV changes, and we saw that L-cell cell showing the HPV changes, and then there was this full thickness dysplasia, which you see throughout with no invasion, and this was CIN3, okay? So what are the implications? Now, the TBA system reports, we report these cells according to the TBA system, but the implications of that reporting pattern is being as part of the ASCCP, or the American Society of Colposcopy and Cervical Pathology reporting. So ascus means reflex HPV testing and follow-up. So whenever a diagnosis of ascus is offered, there's an reflex HPV testing, and then there's a follow-up of 6 months to 1 year that happens at also our center. In contrast, because the chances of CIN2 and CIN3 in ascus are 10 to 20%. In fact, L-cell also most of the cases regress. So that's why they are just followed up, and the chances of significant, when I say CIN significant is 2 and 3, are 10 to 20%. In contrast, ascech becomes a candidate for colposcopy assessment and a simultaneous biopsy if something sinister is there. Why is that? Because the chances of significant sin, that is CIN2 or 3, is 30 to 40%. So ascich lesions have more chances to harbor a underlying significant CIN in contrast to ascus that has 10 to 20% chances. So this is from the ALTS study group, that is the ascus LCL triage study is what the background developed as, that they were ascus and they started to subjecting those cases for reflex HPV testing. All right, and now coming with this background towards our experience at Tata Hospital, that we tried to evaluate what were the ascus lesions or what were the ascich lesions leading up to, and how we experienced and what we saw in those particular cases. That was, now what happens at EMH is we don't have an organized cancer screening program. We have an opportunistic screening program that the patients come, and I would say the women come, we don't call them patients, for a screening on their own, and then they have a pap test. So this was an analysis over 4 years, and the total number of smears that were examined were 9190. Unsatisfactory rates were 6.1%, and that is actually generally in our scenario, because with the conventional pap smears, one of the limitations is the unsatisfactory smears, and that's not a very good figure to say. So 6.1% was the unsatisfactory, and like I said, women, the way they come is for routine and annual screening at TMH. Initially, how it happens at our center is initially all these women are screened with pap tests and subsequently a visual inspection with acetic acid or Lugol's iodine. And in case they are positive, beat on simultaneous pap and visual inspection, because 2 is better than 1. And I'll show you why there's an evidence what was unraveled with one of the premier studies at our center. So these are subjected to colposcopy and thereafter a biopsy in all those positive cases. So pap smear positive, a biopsy. Something sinister on visual inspection, a biopsy, in contrast to the Western were very selected cases on the colposcopy. In fact, colposcopies are also very selected in terms of further biopsies and triage. So this is the evidence with a previous study from Dr. Shastri at our preventive oncology, and you must be seeing a lot of papers with this group, and Dr. Shankar Narayan, and Dr. Khane is also there. So they evaluated this visual, cytological, and HPV screening methods for early detection, and they found that the most sensitive was the visual inspection method, and the most specific was pap test. So that combo goes well when we are trying to triage such a woman, and that's how, with this evidence, this pattern of screening the patient is going at our center. So like I said, all ascus cases were recommended HPV testing and follow-up after 1 year in the study that I'm sharing with you, the ARC series of ascus and ascich. And ascich cases were recommended colposcopic assessment and further a biopsy. So that's how we roll it at our center. But that's the limitation, because poor compliance and limited follow-up is always a limitation, and that was with our study also. And of course, HPV testing in all ascus cases doesn't become feasible, because depending upon the patient compliance, she wants to undergo that test or not, and then the cost constraints. So initially, the asc cases, or the atypical squamous cells, were 103, and that is 1.12. The asc-cell ratio was 0.36:1, and that's quite okay, because the usual asc to cell ratio, depending upon the labs, generally is 2:1 or 3:1, and that is, so we were quite okay with this ratio. And the ascus to L-cell ratio was 0.69:1, and this is an important quality indicator in a lab when you're dealing with these, how many of your cases you're calling as ascus, because they should be actually 5%, you shouldn't go more than that. And 2:1 and 3:1 is the good asc-cell ratio for as a quality indicator in your lab. So there were 74 cases that were initially called as ascus, and there was 29 cases that were called as ascich. And we just tried to look at those cases which were ascus and ascich, and we found on review of these 74 cases, actually there were 12 negative cases, kind of overcalled as ascich, and there were actually the ascus were 49 in these, sorry, I was saying about the ascus lesions, 74. So ascus were retained in 49 cases, and this is the breakup of the lesions. You can see L-cell came as more common, 9 in those sort of ascus cells that we initially called in the term numbered 74. As sketch lesions were 29 and 7 were negative, kind of overcalled, and you can see ascus was 1, and there was a squamous carcinoma which kind of was underplayed, which for the obvious reasons, and HSIL was more common. So you can see the ascus on review also had more of the HSIL in contrast to the ascus, which had more LSIL. So there's always a chances that the ascus lesions have more chances to be harboring an underlying LCL in contrast to ascus, which have more chances to harbor significant cell that is HSIL. So the overall diagnosis in terms of the ascus 19 cases, like I said, the overdiagnosis was as a result of atrophy, which is again a pitfall, inflammatory atypia, air drying, and a polyp. So these can be reasons for overcalling, and I'll show you some examples. In contrast, in ascech, the overcall in 7 cases was mostly related to immature squamous metaplasia. So like I told you, the cell type is metaplastic type. So you can kind of overcall it, or you can miss those cells. So these were immature squamous metaplasia most commonly. Excuse me. An atrophy and inflammatory atypia in a single case each. Excuse me. So this is an example of an atrophy overdiagnosed as and you can see this is red atrophy, which is overdiagnosed, and sometimes metaplastic cells in a hemorrhagic background when the smear is not very well collected, that can also cause a pitfall in terms of overcall. Squamous metaplasia, you can see here the borders edged out. The chromatin, you can see whenever you are dealing with those very denser cells, it's good to look at the cells at the periphery. And you can see this columnar cell with developing these borders, actually the metaplastic cells for the postgraduates. So that's how this honeycombing kind of cluster, it's minimal overlapping, not really balls and cell balls. So this is an endocervical cell, and this is metaplastic, which was kind of called as sketch. And similarly were these cells, but if you look at the nuclear border, it's quite smooth. There's uniform, not too much of denser chromatin that I always pay attention to when I'm looking at the sketch or the HSIL cells. So finally, on review with the ASC cells 70, there were 50 ASCAs and 20 ASCETCH. So we were able to, on review, and that's our practice. We always try to review or try to make sure as much as possible. In contrast to the Western world, then you can just send the patient for ASCAs for reflex HPV. We have our limitations. We have to find out our ways, and I think review is a good way of dealing with our cases. And relating to the HPV results, which were limited, we found that HPV positivity was more in the ASCAs, and that looks a bit significant in contrast to the ASCETCH further on. Looking at the review, so you can see here in terms of the histopathological findings, SIN1 was more common with the ASCAs, like I showed you, and ASCETCH has more chances for relatively significant SIN, that is SIN2 or SIN3. So that's the why this terminology has its clinical, and practical bearing. And this is our comparison with another study from India. You can see here the number of cases and almost equal number of NILLMs, negative intraepithelial lesion or malignancy, LCL 0.83, 0.19, significant CIL, that is the HSIL 1.4. This perhaps could be because we are a tertiary cancer referral center and it's not an organized cancer screening program, and women come on their own, so there could be something referred cases that sort of come to us in a certain way that could actually kind of, but that's not, again, too much, in terms of the significant LCL. Detection of squamous carcinoma screening scenario is a failure, actually, of a screening scenario. But every time there is a screening in any part of the country, there are incidental squamous carcinomas coming up, because the sad part of the story is we don't have a nationwide organized cancer screening program. And I think all of you will agree with me on that. And there were cases of adenocarcinomas as well. So like I said, when we compared with this study from Institute of Cytology, Dr. Pushpa Sadani group, and we found that ASCUS showed SIN2 and higher in 4.3, in contrast to theirs is 3.2% cases, and ASCETCH was harboring 3.3%, they found 30.8. Again, the referral cases in our center is creating kind of this bias. So these were the limitations in our study. And HPV positivity is not feasible in all cases. So what happens is, like I told you, the way the workflow goes, that there is something abnormal on Pap smear, there's something abnormal on the colposcopy. So see and treat is the policy that happens at our center. So anything abnormal on Pap goes for a biopsy. Anything abnormal on visual inspection goes on biopsy. And we see a lot of squamous metaplastic cases even in any screening. But I used to feel at some point in time that is there an over biopsy? But then looking at the incidence and prevalence of the cancer, visual screening is not very specific. It's like 67% specificity, but over biopsying, over diagnosing lesions is okay with our population. So these were the conclusions that it describes a screening approach in limited resource settings which offers some benefit to at least some women, and critical review in terms of the ASC lesions helps in filtering out these cases into more definite categories. And the chances of SIN2 and above are more with AS-sketch. So significant CIN is, like I showed you, is more with AS-sketch in contrast to ASCUS, which has more chances for the HPV and LCIL cases. A higher number of inadequate cases and referral bias for high-grade lesions is a reality. You can see here the 6.1% is not a very good percentage, and this needs sustained efforts in terms of pursued screening programs that we can one day have an organized cancer screening program with a wider coverage. So any questions at this point in time, and I move on to the other aspect of the my talk, that is atypical glandular cells. Any questions? Yes. Okay. Okay, immature squamous metaplasia will be a cell that has a little higher NC ratio. The chromatin is fine, you have well-defined borders, and you see, like I showed you, some endocervical cells which are having a network in cells undergoing a metaplasia. When we're looking at CIL is what you want to do. So LCIL is a cell which you will see in the intermediate cell type. That will be a little higher cell, and it will have the intermediate cell nucleus with coarse chromatin and coilocytic atypia, so we call LCIL. HSIL will be a cell that can masquerade an immature metaplasia, and that you differentiate with the chromatin aspects, because you will not see denser clumped chromatin. If you draw 4 quadrants in a nucleus, I feel luxury if you have a 60x microscope, madam, actually. So that helps you, in 4 quadrants you see the different chromatin aspects that is more towards the dysplastic or the HSIL in contrast to squamous metaplasia. And of course, LCIL you can always, with the intermediate cell coilocytic atypia, you can differentiate. Does that answer your question? Okay. Well, that's a very good question, actually. Inflammatory atypia is, again, a reactive atypia that you can see. You will see, again, a background of inflammation, but that doesn't deter you. You can see an atypical dysplastic cell even with inflammation. What I see is if you're seeing things like nucleolar prominence, if you're seeing the chromatin border is not too irregularly thickened and there's no heterochromatin, it's just a nuclear size is increased and you see some nuclear, that's more like reactive atypia in contrast to the dysplastic, where chromatin pattern is very important. Thickened nuclear membranes, NC ratios can variable because depending on LCIL or HSIL. So it's chromatin and nuclear characteristics which are important. The chromatin is very fine, uniform in reactive lesions, and you will have denser clumped coarse chromatin in dysplastic cells. So that's important, and nuclear membranes irregularity. So coming to the next part of my talk, that is the glandular cells. We'll start with a case scenario that I came across of a 39-year-old lady with a blood discharge in 3 months. She had undergone a dilatation and curettage with unknown results, and she underwent a pap test. That's what we got to ourselves. And this is what it showed. You see this, not a very, very good slide, but that's the best I could share with you. So this is a prominent nucleoli, little edged out borders. So this tells us that we are not usually dealing with a squamous cell, because they're generally, if they are, what shall I say, dysplastic, you will see more clumped kind of chromatin pattern, unless there's a poorly differentiated squamous carcinoma, which is very obvious. So we can really say that these are glandular cells, and there's a little bit of overlapping here that kind of worries you, that are you dealing with something atypical in terms of the glandular cells, and this is the background intermediate cells and superficial cells that kind of give a contrast towards these cells standing out really. This is what it was labeled as, atypical glandular cells. And what are atypical glandular cells according to the TBS system? Okay, so we now define them more clearly. It's not like a runaway. You call it atypical glandular, and that's it. You should try to do that. Are these atypical endocervical cells, and endocervical cells that display atypia that exceeds the reactive? That's kind of a subjective interpretation of reactive regenerative atypia, but it's less than an endocervical adenocarcinoma in situ or adenocarcinoma. I'll show you how an AIS, very unusual lesion, but it shows up. And what are the atypical endocervical cells not otherwise specified is the other thing we have to mention in terms of cell strips, sheets, nuclear enlargement, which is really 3 to 5 times more than the usual endocervical cells. And then atypical endocervical cells favor neoplastic. So this is not otherwise specified. This is favor neoplastic when you see cell strips, sheets, overlapping, clustering, crowding, rosetting, feathering. Oh, I'm so sorry. It's not it's feathering. Moderate to marked nuclear atypia. So the architectural patterns are very important when you're dealing with the glandular cells. So balls, cell balls, clusters, overlapping, feathering, and strips. I'll show you some of those examples. And then you start looking at the nuclear features to make your, and those could be more like neoplastic cells. So atypical, then we have the atypical endometrial cells that can be not otherwise specified. It's a bit convenient when you're seeing more than 40 years of a woman in which you're seeing endometrial cell clusters, which overall is sizes to the intermediate cell nucleus. That's a comparison towards the endometrial cell. You see atypia in those you have to mention. If it's in terms of the phagocytic cells per group, with mild nuclear atypia and irregular, ill-defined cell borders, it's very important in endometrial clusters. And then atypical glandular cells, when you can't say that this is endocervical or endometrial, so but you still want to restrict to, could be neoplastic. And there can be a lot of other tumors, ovary, fallopian tube, which can actually come. So those could actually come in the category of atypical glandular cells. So these are the 4 different kinds of atypical glandular cells, and this is a good source actually. I borrowed these slides from the NCI Bethesda ASCP on the website. It's a good source to kind of check your skills in terms of interpretation. Which do you think is 1 or 2, 3, 4 looks really neoplastic? Okay, that was a bit of a quiz. And none of them actually is. So this is repair here, okay? And this is radiation-induced. History becomes very important when we're dealing with something sinister, and we know there's a history of radiation-induced. Tubal metaplasia, you see these fine, elongations of the cilia, and that even if it's, when you have a lesion like this, you start thinking of AIS, which has a very feathering border, if you see the online resources of adenocarcinoma in situ. And IUCD-related changes leads to vacuolation in the cells, which kind of gives you an impression of signet ring cells. So these are the 4 pitfalls that one needs to know, repair radiation tubal metaplasia when you're dealing with the atypical glandular cells. And this is what I mean by saying feathering in adenocarcinoma in situ. It's a very, very rare. We've seen, I think, 1 or 2 cases. And this, again, from this NCI Bethesda system. This is the feathering system. You see, whenever you see this feathering system of these glandular cells, this, it's very, very strong hint. It's like a spot for an AIS or adenocarcinoma in situ. And there could be then intestinal kind of differentiation. This is like endocervical pattern. This is like intestinal when you see those goblet cells. So that's also an adenocarcinoma in situ kind of lesion in adenocarcinoma. And this is the case that I was talking to you initially when I began with those atypical glandular cells labeled as, and then there was an endometrial biopsy, and that clearly showed an adenocarcinoma. Okay, and you can see here the mucus, the glands showing sufficient atypia in terms of the architecture and cytology. And what I use generally as a good panel to make, whether it's endometrial or endocervical, we don't have P16 regularly doing it. So P16, CEA is good for endocervical, and Vimentin and ER are good for the endometrial. So this rules out an endometrial here because the glands are negative with Vimentin, and ER is also negative. So this was in the endometrial biopsy, I call this as an endocervical pattern of the adenocarcinoma in the endometrial biopsy. And then there was a, this is what I called it, and then there was a cervical biopsy they followed, and that showed the same exactly adenocarcinoma. So that was an endocervical type of an adenocarcinoma, which kind of gets missed because in the canal up, the lesions might not be easily picked up, and the patient is having an overwhelming disease as we see them in terms of, uterine and cervical involvements. So on review, this is clearly a neoplastic. These were the other clusters, and I think you will agree with me that these really, you can call them the cell ball arrangement, prominent nucleoli, thickened borders. Look at this chromatin. So this is all towards atypical glandular cells. These were neoplastic cells. This was the review. And that's another case, 2 cases that I came across of AGC favored neoplastic. You can see again the cell arrangement is very important. I couldn't pick up all the cells to show you because they are on 3-dimensional clusters. So you will see some cells, you won't see some other cells. And that's the whole thing, because you see this very thickened nuclear membrane, atypia, hyperchromatic, and prominent nucleoli. This was an ovarian carcinoma with peritoneal mets with presenting on a pap smear, because this patient had widespread disease and she underwent a pap smear at our center, and we call this as neoplastic. We didn't classify it. And this was a carcinoma of endometrium stage 1B. So that brings to me to share with you our experience, and Mrs. Dula Najit was I think many of you would know her contributions in cytopathology at our center, and she did this study, and we had a chance to kind of see these cases. What lies beneath an atypical glandular cells, she called it as a hit or a miss scenario. And these were the number of conventional pap smears over an 8 years period that were analyzed, and initially 74 cases with glandular cell abnormality. When I say GCA, it includes atypical glandular cells as well as the neoplastic, that is the AIS, and you can see there was only 1 case of that feathering pattern of AIS that we came across, and adenocarcinoma 37. So AGC not otherwise specified were 7, AIS1, and benign pathologies in terms of mostly hyperplasias that we see were 6, and AGC favored neoplastic. This was the respective figures. What happens is AGCs kind of get overdiagnosed when there's actually a CIN3 involving a glandular crypt. I'll show you an occasional example that happens with this. And again, like we did a review, 15 were false positive, including 11 reactive in this particular study, and 4 AGC NOS was retained. So mostly the 11 reactive or the negative benign pathologies, that is hyperplasia. And this is one of the figures. This we kept retained this as AGC, even though there was a hyperplasia. But because the what we looked at, and she actually detailed analysis she did, was the architectural patterns, the cell balls, feathering, the strips, and this is an abnormal cell cluster, which you will agree with me. Of course, this is not very much in focus, and this didn't show up further on the the biopsy, but we retained it as an AGC. NOS we called it, and this was actually a CIN3, and what happens is you see this cell ball cluster, and you see this flattening of the nuclei at one end. So whenever you see a cell ball cluster and a flattening of nuclei at one end, it's actually a CIN3 involving a glandular crypt, which is giving you a false impression of an AGC. So that's one I find a usual recipe. And finally, what again was concluded in this study was re-evaluation based on stringent cytomorphological criteria enhanced the overall agreement to 95.5. When you look at those clusters, feathering, strips, and then all those atypical features in the glandular cells. And that's important. You see dissociated atypical cells with irregular nuclear membranes and chromatin pattern is always very, very helpful features. And with this, I would like to wind up my talk with this recent photo. Anybody can spot what is this? My recent trip to Sydney, it was a light show there at the Sydney Harbour. So, and this is Brisbane. Thank you very much for patient hearing. Any questions about the AGCs? Is it all clear? It still remains a problem. We see more of these squamous lesions. Yes, ma'am.
HPV testing, when should we ask it with past
Reflex, I think Dr. Kirti will go more on the details, but I think reflex HPV is ascus, whenever you're seeing an ascus lesion, it should go for a reflex HPV. That is the ideal scenario. But what happens is patient with LCIL also kind of want to have a double check, but HPV testing on its own is not enough. You need to have a lesion to further triage the patient. So ascus is I would choose on ascus, should go for reflex HPV testing. Thank you very much.
Can we have the next talk? Yeah. We can circulate that attendance sheet, please, if those of you who have not signed it for the certificate. Yeah. Okay, so I think after Dr. Eki, such an excellent coverage of the atypical areas, it's an excellent platform actually for me as the speaker after you, because I cover all those gray areas. That what happens to all these atypical, what do you suggest as a pathologist, and what is recommended when, and what do we see when we actually put all these ancillary tests into play. So can we have the... How do you move it ahead? By this one. This one, no?
That's for the next slide.
Okay. Yeah. So I'll be covering the ancillary techniques in gynaec as well as non-gynaec. So I just want to tell you that this whole area is coming up a lot, and we're going to soon talking about the liquid biopsy and molecular cytopathology. And if in this lecture I can take off the fear of that molecular word, my job is done. So it's nothing to get so psyched about a molecular. It's nothing. It's just when you apply molecular studies on these cytology specimens, anything, exfoliative, gynaec, non-gynaec, FNAC, whatever it is, you apply a molecular test, and this is actually becoming a huge area in clinical practice. And we've seen it with HPV, we've seen it with gynaec and HPV, that how one single brush, one single test can, do research, can do diagnosis, can give confirmation. So it's really changed the scenario. And it's a good time to be in pathology because of this. But what I'm going to do in this lecture is that I'm going to integrate these molecular tests into your routine clinical practice. So it's not something that is done somewhere in the US, UK. No, it's happening in India. And let's see how we can beat around this. So I'm going to teach you how to drive in utero, because that is what it is actually. And we have to learn these techniques whether we like it or we don't like it, because whether we like it or not, tomorrow the clinician or the Google savvy patient is going to come and ask us something about it. So it's just an exercise to learn in utero. So what is the advantage of cytology? Using cytology as a material for ancillary study has got a huge advantage because it's fresh. Remember, it's fresh. Most of the fluids do not have a fixative. Okay, actually FFPE is called the four-letter word in molecular practice, because it is so difficult to get the DNA and the RNA and everything out of that formalin fixed paraffin embedded tissue, that the way hemat is preferable for molecular people, same way cytology specimens are preferred over histopathology specimens for doing molecular studies, just because of the ease of doing the test, because there is definitely better preservation of DNA and RNA. And you can use all possible tests in this. So which are these cases, which are these samples that you get? So there are direct smears, there are cytospins, there's liquid-based cytology, and there is cell block. So all these things are there. For what do you get them? The most common specimen that you get is the cervical smear, which you get, and then the molecular test used in that is HPV. You get thyroid FNAC. Abroad, they are not even bothering to classify morphologically thyroid. And, they just do the molecular test and they decide on top of that whether it's follicular, papillary, blah, blah, blah. You will not believe it. Sometimes we get the second opinion cases for papillary carcinomas, to rule out all that, even on IHC. There is no IHC marker. It is just morphology, and then it's molecular. So, you have to interplay between these areas. Then the pancreatic cyst fluid. It's a huge area. Pancreatic cyst area is a huge area. I'm going to touch upon it just in one slide because it's a huge lecture in itself. I think Amita madam will be covering it later. Then there's urine. We all know that urine, you hardly get to see any cells in the conventional, and there is so much resting on that cytology report of yours. So how do you beat that problem? And primary lung adenocarcinoma. Sadly, very sad state of lung cancer, the amount of smoking, the amount of pollution, the amount of passive smoking. We are not smokers, but we can still get lung cancer because of the atmosphere that we are living in. And because of that, there's constant, about targeted therapy, which I'll be covering again in the slide seminar. And that's why this area becomes very important. So let's first just follow up with Dr. Bharat's talk. And I'm just going to go about what is the transformation of the cervical smear, or the molecular PAP as I call it, and the new cervical cancer screening guidelines. So let's just touch upon these areas. As everything else in the dismal picture in the country, this is also a very dismal picture. Nobody wants to do anything about it, or they think it's too complex to pick it up because there is a huge task involved. There is cytology, there is HPV, there are no people, there are too many people. So, it's too crazy. But whatever the situation may be, the fact is this: we should be ashamed. 27% of the world cancer cervical and 27% of the deaths are all happening in this very country. So till the government decides to do something about it, it's only left to the gynecologist and to the pathologist to do something about it. So if you, search this on the net, you will be bombarded with information. So what I've tried to do is to squeeze out all that information and, present it in a nutshell. Yes, these were the guidelines earlier. So this was the 2007 guidelines, where a case of ascus had to be taken up for HPV because it was a gray area. Well, the guidelines have changed. So according to the 2012 Annals of Medicine and the US Preventive Services Task Forces, all these bodies have come together, whether it's the American Cancer Society, the American Cancer Society for Colposcopy, cervical pathology, and clinical pathology. And they have all decided the same thing. This is all that is to be known, the red line, that now women between 30 to 65 years should be screened either by only a pap smear every 3 years or by a co-test every 5 years. Please remember, annual pap smear is out of the window. It's not recommended. It is not to be done. It is not to be done. Even if somebody is doing a pap smear, whatever the pap smear is, LBC, conventional, it does not matter. Pap smear is every 3 years. And the moment you couple an HPV with it, you can do it every 5 years. Now, if you understand the monetary implication of what I'm saying and the loss of ambiguity and a clear diagnosis of what I'm saying, you will understand that it is the obvious choice. Today, a pap smear costs somewhere between 500, 300, I don't know, whatever the rates are. While a co-test, HPV and pap smear costs around 2100, 2500. So actually, if you do it every 5 years, you're actually, the patient is the same money that is going. But there is no ambiguity in the report. It's a final report. There is better patient compliance. And that is why the whole world has come to this agreement. So it takes a long time. Cancer does not happen suddenly, and HPV takes a long time. Yes, there is an increased sensitivity when you add in a molecular test for all possible diagnosis. So the lecture cannot go further. As you say, whatever the people before you have done, if you don't acknowledge that and take in a lot of that, nothing new can come out good. So we have to, salute to this man and his wife, who contributed a lot to his studies actually. And it took him a long time before the pap test actually came into, focus. And it became so popular because it caused 70% reduction in cervical cancer. And it was like, lady, have you been baptized? Like, it was as important as baptism to have a pap smear done. So, I mean, hats off to this man. And of course to this too, because it was Zurhausen who actually came up with the fact that cervical cancer is only and only caused by HPV. So you know the reason here. See, there may be many cofactors like, lower socioeconomic status, this, that, lots of things, immunity and all. But the etiopathogenesis is only one. There is one virus, you screen the virus, you see what damage is done to the cells, and you prevent this cancer. So I know this is a little, when all these things start coming, some people switch off. But please don't switch off, because it's very important for molecular. Just one line, that it does not matter if the cervix is infected with the HPV. HPV is like the common cold of the cervix. Anybody who has sex is going to get HPV sometime in their life. It is whether that HPV is high risk or low risk. If it's high risk, how long has it stayed in your system? If it has stayed in your system, is it integrated into your host genome? And only when it is integrated into the host genome are these proteins going to get released, E6 and E7 mRNA. And once they get released, you will see the overexpression of P16 on IHC. So until that happens, it can regress. Is that clear? So when there is HPV infection, what you're going to see cytologically is either NILM or ASCUS or LCIL, right? Moment integration takes place, you can still have LCIL. Somebody with integration may still have LCIL, but now the chances of a SIN2 or 3 are higher. Now, what does the gynecologist want to know? As the doctor who's sitting in front of the patient, you want to know only whether this lady has a treatable lesion or no. Am I supposed to treat it? Am I supposed to follow it up? That's all that she wants to know. So anything above SIN2 and above is treatable. She has to treat it, right? It's not going to regress. It can, but the chances are lesser. So this is what just one needs to know. And there are a whole lot of genotypes which have come into play. Now, why these genotypes are important is a very common question that somebody will come and ask you, oh, you're a pathologist, you do cervical smear, I've got a daughter, should I give her the vaccine? Once I've given her the vaccine, does she need to have screening? Yes and yes. I have 2 daughters, I will give them the vaccine. I have not got the vaccine, so I better screen myself. And even if my 2 daughters get the vaccine, they still need screening. So are the 3 answers very clear? Why? Because the vaccines only cover 16 and 18. What about the other genotypes? They are not covered, so you have to get screened for them. The vaccine has the best effect before the first sexual exposure. Half the people have taken vaccines after the first sexual exposure. So yes, you need to still get screened. But do you need to take the vaccine? Yes. If it can give you some protection against a deadly cancer, why not? Okay? So that is the thought behind these things and why one needs to know. Now the problem, as I said, only if it's persistent is going to cause cancer. And as Dr. Bharat also mentioned, about half of these CINs will clear. So do these women need to be psyched out? No, they don't have to be treated, because when they get diagnosed with LSIL, they are in the high of their life. They've got married and children, you know, they're into their jobs, they're doing well. So they don't need this. They don't need a diagnosis of ascus or LSIL. And even if they have, they want to know that are they supposed to be treating that, or are they supposed to be focusing on their other aspects of their life? And that is how it comes about. So what is the goal really of Pap testing? Why are we doing Pap testing? The whole idea is to identify these pre-cancerous cells before they transform into cancer. So as he already said, that there are certain limitations. I have been using conventional for ages, and I'm still doing. There's nothing against conventional. But then when there is a better thing to do, why not? So what goes away is that the ambiguity goes away in an LBC. The same sample goes for HPV if and when there is a problem, as Dr. Rekhi suggested. And LSIL gets confirmed. You have an evidence-based medicine report. You know, you don't have to go through a court case, unfortunately, if something happens. And there is better patient compliance. There are 3 very important steps to an accurate cytodiagnosis. First is, there has to be a good smear. What is not on the smear cannot be seen. Nobody is going to catch anybody if you miss something. They're going to say, you didn't see it. They're not going to say, we didn't put it on the slide, you know. So this way, we have to do away with the fact that did that gynecologist know how to spread properly or to fix properly. She's supposed to be just taking a sample from the cervix and putting it inside the LBC container. Whatever she has taken will come onto the fluid. So, you know, that problem is taken care of. There is no substitute for careful screening. Everybody has to spend time on seeing. Now, the time spent on seeing reduces when you see an LBC. And the clarity is amazing. And of course, it can be followed up by an adequate confirmatory test. And there has to be a beautiful correlation between the cyto, HPV, and the histo. This is what a conventional smear looks like. No problem. Very nice. But supposing this red area was the area where the precancerous cells were there, all the other material has come on the smear, and you know this red material goes into the dustbin. It doesn't come. You get a false negative report. While here, you immediately, everything comes on. You don't miss anything. I have got cases in which the HPV was sent in a sampler by a different sample, and LBC PAP was sent in a different sample, and the LBC showed LCL, but the HPV is negative. Is that possible? No. So we told them, don't play around. Same way, you know, so many times, cross thing also happens, because we do so much co-testing that you see all kind of things, you know. So you have to, everything has to fit in like a jigsaw puzzle. And this is what an LBC smear looks like. I mean, we're all pathologists here, but even I had this presentation in a Gynaec conference, and even the Gynaecs could make out that this is a too beautiful a thing as compared to a, just see the difference, and you know, it's just staring at you in LBC. This is what an NILM looks like in LBC. All the inflammatory cells will get huddled together. They'll be there to see, but then you can see the cells very clearly. This is an actinomycotic colony. This is an LSIL. I don't think I need to go into this. He showed it very well. This is a beautiful case of LSIL. This is an amazing coilocyte in all its glory. So just see the way it is seen, the nuclear D, because the fixative is very good. Okay, and it is stable at room temperature in that vial for a period of 6 weeks. You know, women, they've just gone to a Gynaec, chalo, pap smear kar lo. After that, they've gone for a holiday, they've got busy in their child's, you know, school, this, that, they've forgotten. Suddenly, after 2-3 weeks, they get a pap smear report saying ascus. Okay, now what do? They go back to the doctor. Ye kya hai? He can say, okay, you can order an HPV now. Because that sample is stable for 6 weeks. Somebody can go to the States also and come back and still order the reflex test. So it's not that you have to do it then only. Co-test is the preferred strategy. Next thing is at least reflex it to the abnormals, ascus and LCIL and whatever. This is an HSIL, very beautiful HSIL. This was also a case of HSIL. This was a squamous cell carcinoma. These are all biopsy-proven cases, the pictures that I'm showing over here of the cytology. So this is how a pap smear report looks like at our center. So we give the the Bethesda categories, what is the specimen type, the adequacy, the inflammation, the abnormality, and then we couple it with the HPV, detected, not detected, if detected, which type of genotype. Because if it's low risk, they need not bother again. Nothing is going to happen. It's only the high risk types which are a problem. And then, of course, the advice and a comment that you give on the pap smear becomes very, very important. So according to the latest guidelines, that is what it is. If you've not done an HPV, you must do it if you've got an ascus. As Dr. Rekhi already said, with an ascus, you go in for a colposcopy or a biopsy. If it's L-cell, again do an HPV test. If it's H-cell, just straight away go for a biopsy. Squamous cell carcinoma, same. So, that's the way the advice runs, and if somebody asks you. Now, as far as reporting is concerned in a biopsy for cervical screening, sometimes you get them together or as a follow-up. It's a little different. When you report it according to CIN 1, 2, 3. But as far as a gynecologist is concerned, they're only concerned for practical purposes on two things, whether this is a low grade or whether this is a high grade. So whether you call it a CIN 2 or 3, it's going to get clubbed in the same category as far as they are concerned. They only want to know, is it CIN 1, right? Or is it CIN 2 and above? So let's just go through some of our data. So we had about 36,000, nearly about 37,000 cases so far, of which you can see a very big number is still conventional, 20,000. But there are about 16,000 LBC cases. And you will see the way the people are opting for LBC, because it started with a modest number of 111. And now you can see it's like 5,000 last year. And this year, just till April, it's already double of conventional. So it was just, this is conventional, LBC, and it's gone, and now today it's double. So obviously there must be something good in it that everybody is wanting to, change that. It's less of a headache. So this is what you see. Immediately there is, this is your NILM, and the abnormals double. So abnormals and conventional are 1.1. This is same people, same pathologist, seeing both the cases in the same manner. There is no bias. Everything is together in the tray. It does not matter when you're looking at a conventional LBC. Everything is the same. So the abnormalities detected were double. The unsats were, even in conventional, the unsatisfactory was only 0.3, but here it was just 0.1. And this was the abnormality distribution, as you can see. And L-cell is the most common abnormality detected in LBC, because you make the switch from ascus to L-cell very easily, because you can see the features better. And this is what everybody world over has seen, that there is a 4-time increase in LBC the moment you switch over from conventional to LBC. This is what everybody has seen all over the world. And this is the kind of HPV that we see in our country. Now, about 9.4% of us are infected with HPV. Right? That's about 10%, incidence is there. And as you can see very clearly, that is not only the 16 and 18, it's all of these which are not covered in the vaccine. So the cervical cancer screening guidelines do not change with the status of HPV vaccination. Very common question asked to everybody. Now, if you look at these HPV cases, we tested it in about 5,700 women. And a point very clear was that out of all the detected cases, 70% were actually a high-risk genotype, of which most of them, yes, were 16 and 18, followed by the others. Now, what I was talking about, the integration, you can do anything to see the integration. Whatever it is that is available in your center or to the lab that you send the cases to for referral. So we were doing chromogenic in situ hybridization in the middle to see whether the virus is integrated in the host cell genome. But now, since a better test has come, we are doing the P16 NKI. Some people like to do the E6, E7 mRNA. That I leave to choice. Whatever ancillary test you want to do, but sometimes it is required. So let's just see this, why it is required, because you'll see so much overlap that some of the cases which are positive for one will not be positive for the other, and so forth. Now, again, a very common question asked is that sometimes you will get an HPV positive and a cytology negative. In fact, that day we were discussing with Dr. Kedar, and he was saying that now the Indian government is thinking of maybe making HPV as the primary, screening test. And I was like, though we are doing so much of HPV, I would be a little wary about that, because there are so many women who get detected as HPV positive, but they don't have anything. They are NILM. So they will get uselessly psyched now. Because if you look at the abnormality detected on pap smear, it's about 1, 2, 3%. So you're psyching out these many women. Now you'll be psyching out 9% women. So, we were debating, and he was saying, but it's not possible. There are not so many pathologists, there are not so many cytologists gynecologists, and the screening program will not be effective. So I said, might as well do both at least. So somebody has to be positive for HPV, plus has to have an abnormality. Before, you psych out that lady that, okay, now you've got thing. So I'm just saying that this is the kind of debates that are happening, but don't be surprised if with the current government, suddenly HPV becomes the primary screening. And though we have it, I would not be the happiest person, because I see the chaos with an HPV positive. And that is what the thing is. That's why I always tell everybody the recommended thing is co-test. If you can't afford it, just do a pap smear. If you come across an abnormality, reflex an HPV. That's the best way to go about it in a nutshell. So, but I will just touch upon these ancillary techniques because they're important, they're good to know. So as far as in situ hybridization is concerned, Kish, that's my level of excitement about this technique actually. And I've been jumping around with this technique for the last 2 to 3 years. And why? Because fish is so difficult. Believe me, I see fish also. It's very difficult. As a pathologist, as a histopathologist, Kish is amazing. Because you see the morphology and you see the molecular problem on top of that morphology. Right? So it's like reading an IHC, it's just that now you're reading signals instead of. While in fish, you're sitting in a dark room, you don't know anything, you don't know the morphology, you don't know, you're just staring at those signals. And there are a lot of problems associated. Every organization cannot afford a fluorescent microscope. Everybody cannot afford a geneticist. There's a whole system that comes with fish. While for Kish, any lab that is doing an IHC can start doing Kish. It's like a marriage between molecular and IHC. So we did Kish for this pap smears for about a year before we moved on to Kish. To P16, and this is what we saw. It used to correlate so well. So whenever we had an ascus, we would see that it was obviously HPV positive, but only few cells were showing the infection. While in LSIL, they were positive. Integration or non-integration was dependent on the status. And in all NILMs, even if there was HPV positive, Kish was negative. You understand? It was a passing by infection. So this is what it looks like actually, just to show you. This is how these punctate dots look, red colored dots. The most common chromogen used in Kish is red. You can use brown also, but then it just looks like an IHC. So the red, gives it a different feel as though it's another technique. But now what we are doing is P16 INC4A, which is a proven carcinogen, and this is an excellent surrogate marker for HPV-related dysplasia. So let's just go through this, what exactly is this. Now again, I'm not going to bore you, but basically that's a cell gets infected, the retinoblastoma can no longer this thing, the E2F accumulates, the P16 accumulates, and what you see is a dense brown product. So this is the pathogenesis, how it really happens. We can skip this. But what you see on the slide, what we are seeing on the slide, that you see a cell which is dual positive. So the brown is for the P16, the nucleus, and this is a different clone, the nucleus and the cytoplasm get stained brown. And on top of that, you have a Ki67. So this, ma'am, takes care of all your metaplastic, all your atrophic, because the Ki67 will not light up. So the only cell which is positive for P16 and for Ki, only that is considered as positive. Only that is pre-neoplastic. And that is, I think, a huge blessing. And this is a results of the PALM study, in which they saw that how the sensitivity and sensitivity just jumped for overall 68 to 86, with conventional from 63 to 85, with Shorpath from 58 to 83, and for ThinPrep from 84 to 91. And we did this ourselves, some of the things. Well, this is a part of their study in which they took these HPV positive women, but NILMs. Of course, the ones which are abnormal were clearly abnormal, but even the ones that were NILM, reported as normal pap smear, when you did 34 of these cases, they found SIN2 and above, even in those cases. So that's what they're saying, that if you have an HPV positive, even if you have an NILM, you should still do an ancillary test to see if you're missing out on something. I don't know, this is not what I'm recommending, this is what is recommended. I'm still trying to go around that how it is done. So now this is, I'll just run through a few cases. So this was a 61-year-old lady with an abnormal colposcopy, reverse. See, because after 60, people generally do not do screening. But she had some, she was a lady who demanded colposcopy, and she got a pap smear, was abnormal, and it was an HSIL. And when you have an HSIL, you immediately do a colposcopic directed biopsy, which is the gold standard. And so it was reported as SIN3. This is an LSIL on a ThinPrep on a LBC. You can see the LSIL. And the reflex testing was ordered. It was HPV16 genotype. This is another case, it was a conventional smear, very few cells, but didn't look good at all. You can see, we could make out head or tail. We gave it as Ascus H, and thankfully they did a biopsy, and you can see it is frank CIN. This is the Kish on that case, positive. This is a conventional pap smear, normal, and you have a normal biopsy, and you have a HPV-16 detected. So yes, it happens. The HPV incidence is more than the abnormality, this thing. This was a very recent case, the same gynec colposcopy workshop that I was invited for. The invite was as though like a favor. So this big shot gynec calls me up, okay, I think you're doing some pap studies and all that. So why don't you come for this conference of ours? But ज़्यादा नहीं बताओ, gynecologist को कुछ सुनना अच्छा नहीं लगता और pathologist से तो बिल्कुल भी नहीं. So tell some basic histocyto and go away. So I told, what kind of an invite is this? Like, you're doing me a favor by calling me out. So I said, ki, ma'am, I will say what I know. How much you want to listen, you listen. Rest, you switch off, go out, have coffee, whatever. But I will say whatever I have to say. So I went and blabbered all this nonsense. Obviously, she was only half listening. So after 2 weeks, she gives me a call. I just don't know, us din tum kuch biomarker kar rahi thi. So I said, it's P16. So she said, okay, look, I have this niece who's come down from the UK. She got married last year. She's 1 year married. And in UK, they've done a pap smear and she's got a report of ascus. Believe me, this ascus report is a UK report. Okay. So she came back over here. She got another pap smear done. She got another report of ascus. So she said, okay, so now I have these 2 reports of ascus, and she's telling me, you are this big fancy gynec, but you're not being able to solve my problem. Do I have a problem or do I not have a problem? Can I go back to UK safe and sound thinking that nothing is wrong with me, or am I supposed to be doing something about it? So she said, why don't you do this, whatever you are doing? So I said, ma'am, you just send a sample with HPV and pap smear co-test. Let us see whether she has something, and if something is there, we will just reflex it to HPV, and let's see what is there. So this is what we did. It was not ascus, it was looking like LSIL, that a twilight category. It was a twilight category case. It was exactly that. There were cells of LSIL and there were cells which are looking like they're going into HSIL. Now imagine describing this to a lady who's already, with that thing. So I did a Kish. You can see the integration. I did a Syntec. P16 and KI, you can see. These are the normal cells. There is nothing. There is no staining. This is the cluster. P16 is positive. This is the KI, red dots shining bright. And this is the report that I gave. Kish HPV viral integration to the host cell genome noted positive. Syntec plus dual positivity for HPV and Kish noted positive. Can you imagine that gynec's face when a pathologist gives this report? So she called me up, ये किस चीज़ की report है? ये pap smear की report है? ये सब कुछ pap smear के ऊपर हुआ है? I said, yes, ma'am, ये pap smear की report है. Your niece has got an LSIL which is progressing into HSIL and the HPV genotype is 59. You need to do a leap and take out this lesion. And that's what she did. And this is the lesion. You can see it's frank cyan. See the P16. She wanted it on the tissue also now. I told her it's not required. It's frank cyan. But then, no, you do it. Look at the KI. And this was reported twice as ascus. Twice. So they don't want to, know that. They want to know whether they have it or they don't have it. And so it was finally called cyan. Obviously, she didn't believe me. She took it for second opinion, third opinion. This case now, this biopsy has been reported by 3 pathologists all over the city. So everybody has obviously called it cyan because on biopsy, there's no other diagnosis. But I wonder what those 3 people would have called on the pap smear. So that is what is important. We could have lost this girl. Now she's on an annual follow-up. She's fine, she's treated. But now the guidelines change. So what I blabbered about every 5 years, the moment somebody becomes a patient, they come on annual screening. So the only people today who have to go for annual screening are the people who are already HPV positive or already have an abnormal pap. Is that okay? If both the things are negative, they are free, right? I mean, I make it sound like they're free to jail or something like that, but actually it's quite disturbing, okay, to have a thought that you may have a cancer. So it's quite a sensitive area. Now this is a validation of that P16 which I would like to share with you. Now these are biopsy proven cases and you will see that, it's amazing how this thing works. I mean, I myself can't get over the, the rationality and the objectivity which it brings onto the table. So if there's a condyloma with a low risk, it will not come positive. If you have a high risk, it will show a positivity. Sometimes some people have not even done the HPV, but the pap smear is clearly LSIL or HSIL, and it will show it exactly like that. So, it brings a lot of method into the madness. I would just like to conclude about pap smear saying that this imbalance in the disease burden, that cervical cancer, if you notice, when pap smear got introduced, every year there was a 3.5% reduction in the cervical cancer throughout the world. Now from the year 2006, it is not going down like that. The reduction is not 3.5% annually. So obviously something more is required, to solve this mess. Because as was already told by Dr. Rekhi, and I'm reiterating it, that there is a low sensitivity with some techniques. There is a low specificity with some techniques, And you need something. See, every case does not require everything. Maybe 1 in 100 women will need the P16, right? But then 1 in 100 women needs it. And we should know that it's available. So this is the thing. And what is difference between US and South Africa and India, that the percentages of cervical cancer are so different? It is just because of this. It depends upon your screening and your intervention. Just screening is not important. When are you intervening? How are you intervening? That is what is giving the difference between the African countries and the American countries. So, and of course, there is vaccination, but you still have to do the screening. And cytology does have low sensitivity, and HPV does have low specificity. So we need some promising biomarkers, which are like your high-risk HPV E6 and E7, and the P16. And there are a lot of strategies coming up. Now, they are suggesting self-sampling, they're suggesting methylation studies. So, there is a lot happening in this area because this disease has not been got together. So let's all battle cervical carcinoma together. And I hope I have managed to convey, what is possible beyond the pap smear that we all are so comfortable and sometimes uncomfortable with. So if you are not in this state, I will rush through the non-gynac. Can I? Can I just go through the non-gynac? Or, okay. So let's just touch upon the non-gynac and the LBC. Now, it's not new. Cytology has been used since 1939 for cytology, for giving a diagnosis. But there are obstacles with conventional smears. So the obstacles are a thick smear, overlapping smear, low cellularity. How many people actually see those cells in that urine and that bile? It's such a big problem. Sometimes you have such low cellularity. And clinician is going on telling you there is a mass, you are saying it's negative, so these kind of issues do come up. So it is for these reasons that LBC has come up, and it's really picked up over the last 2 decades and amazingly over the last decade. So, and when you compare it with conventional smear, it shows a higher cell yield, removes the obscuring elements, and it covers the most essential aspect of problem of cytology. Now, urine is just, the numbers change dramatically when you switch over to LBC. So it's the 7th most common malignancy in the world, and every clinician uses these 2 parameters, a cystoscopic biopsy and a urine cytology. And LBC was developed in 1990 as an alternative to this. And you can see that, if you see, they've done about 236 samples, and we saw a similar kind of a thing. You can even detect hemosiderin very well. The cell morphology is also beautiful because it immediately goes into cytolith solution, which preserves the cell morphology and the DNA. And you can do all kind of molecular studies. So we don't have it, but a lot of people, I think, are doing Eurovision fish-based for bladder carcinoma. And of course, there are criteria, and when do you go for it? So when you have a patient with hematuria, or whether trying to do surveillance for a bladder carcinoma, or other applications like reflexing in a atypical cytology, or seeing the recurrence post-BCG. So I'm not saying you must do it for everybody, but I'm saying if a clinician comes back and says that you said nothing, but this is showing this, so you say you may take it up for these reflex tests if there is a clinical suspicion. And this is what the urine for hemosiderin, just look at it, it's just beautiful. So it just stains very well. Same thing happens to BAL. Now the BAL positive in conventional smears that we got was 3.5 and it was 9.2. It's 3 times. I mean, like, you're just picking up anything and everything because it just comes up so beautifully. Now, what are the ancillary techniques that you can do for it? Now, we all are familiar with the endoscopic ultrasound guided FNAC, which Dr. Amita will be covering later. Then LBC, as I've already gone about, that LBC has got a good preservation and a good morphology. FNAC. Now, if you see the thyroid and in the breast, the number of unsatisfactory from 13 and 12 went zoop down to 3 and 6.6. The unsat goes up, the positivity, unsat goes down, the positivity goes up. You can reflex it to ancillary. You don't have to go mad trying to make out something just because somebody's after your life. You can always tell him, if you have so much doubt, just reflex an ancillary test. Okay, and then you can make a cell block and do whatever you want to do with it, because everything is already standardized on FFP, whether it's histology or whether it's IHC or whether it's molecular. Now this was a 29-year-old boy. He's, I don't know why the extra O has come, but this fellow, you know, he's a research student in IIT, and he was going, he's had 3 FNACs. Every way he's got inadequate, inadequate, inadequate. No opinion possible, no cell seen. No opinion possible, no cell seen. He came with such a huge thyroid, you know, this thing. And the moment I put a needle, zoop, at least 20 ml of fluid came out, naturally. Who's going to be able to see any cells inside it? So all that I did was I put it all into the LBC thing, and, you know, we could see some clusters. So you can see the conventional, nothing I can see. But in the LBC, I can see some cells. It's enough for me to call it a colloid with cystic degeneration, right? So he's on follow-up now. He's been coming to us. There's no problem. So what you can do in thyroid, that's what Kane madam and I were discussing now, that, you know, in thyroid, when they see an abnormality abroad, they're taking it up, that aptamer test and a whole lot of other things have come up. Because 70% of all follicular papillary medullary carcinoma is associated with some of the other molecular, you know, this thing. So we don't have to fret and fume. We can say it's cancer. I don't know what cancer it is. You can do all these tests and see, you know. So there is BRAF, there is RET, there is RAS, there's Paxate. There's a whole lot of things, and everything is possible on the LBC container. So this was a FNAC of a breast lump. You can see the amount of cellularity. This is just see the cellular smear. And this is an LBC preparation. This is an FNAC. You can make a cell block out of it. You can do ER, PR, HER2. You can do anything. It's just like any other material. Now I was talking about pancreas. Now if you look at pancreas, I'll not go into the details, but what happens is that you have to realize the limitation of every technique that is being used. So if it's imaging, the sensitivity is only 56%. By the way, cytology, no matter how much we pride ourselves, the sensitivity is only 34%, because it has to be seen. And then, you know, the specificity is 83. Once you can make out that it's cancer, yes, it is. But sometimes you can't even see it properly. And then if you add a biochemical parameter like a CEA, immediately the sensitivity jumps to 73. If you add KRAS, it jumps to 82. So you can see that how the sensitivity increases when you couple more diagnostic things in it. So only cytology, only imaging, only molecular, no. It has to be a combination of each one of them as and when required, case to case. So this was an EUS guided FNAC from the pancreas showing an adenocarcinoma. I think madam will be covering the rapid onset very well, so I'll not go into that. Now, this is the cell block from a celiac and mediastinal node. It's an FNAC. It's a cell block prepared from that, and it's a metastatic neuroendocrine carcinoma. So when this patient presented, it was like a mediastinal lymph node. And then they found a celiac lymph node along the line, and then it turned out to be synaptophysin and EMA positive. This was a cell block of a pancreatic mass itself, which was a neuroendocrine carcinoma. Now, this was another celiac node, but this was a lymphoma. So you can see that, yes, lymphoma, not the ideal thing for lymphoma from the architecture point of view and from this thing, but when you have a diffuse lymphoma, either a diffuse large BCL or a smaller, at least they want to know whether it's a carcinoma or a lymphoma. Forget the subclassification. So, you know, you make a cell block of it, you do a CD20 and a KI, and you at least can tell them that this is a B cell NHL, okay? So what is the ideal FNAC specimen for molecular testing? Yes, quantity has to be there, but more is not always better. Even 50 cells are enough to do a good molecular analysis. The quality is very important, and multiple tests can be performed per aspirate. You can store it for a long, long time, and the purity of the sample is very important. So you should have at least 50% and ideally at least 40%. So even when somebody takes a slide from you or a block from you that we are going to go to this and this lab and the doctor has advised this and this test, if you can't see tumor on it, you should tell them, you know, that there are only 10 cells or 20 cells, you will not get anything. But if you're seeing that 40% or more of the material available has got, the other material can be just blood, it doesn't matter. But at least in the whole thing, if you can see at least 40% of the composition as tumor cells, it will yield a good result on PCR or whatever. Most common this thing is for carcinoma of unknown primary. Most common application for ancillary test in cytology is this, that they have a effusion, they don't know where it's coming from, they need your help, whether it's from the thyroid, prostate, liver, kidney, ovary, colorectal, whatever. You apply the CK720 cocktail, which I'll not go into the details, but for those of you who are not that familiar with IHC, the moment you have anything above the diaphragm, It's CK7 positive, but that you have to add, which is the most popular organ above the diaphragm, the breast. So combine the female genital system with above the diaphragm, that's your CK7 positive and 20 negative. Anything below the diaphragm becomes your 20 positive, but there's also a Merkel cell. Don't forget Merkel cell. All your these complex organs, they are simple viscera actually, and they're all negative CK720. So whether it's the liver, the kidney, the prostate, they're all negative. And both positive is your peridiaphragmatic organs, which are your urothelial pancreas. Now why I'm saying this is very important for these cases. So I'll just show you a few examples how it beautifully helps. We've used it for all over pleural, ascitic, pericardial, everywhere. So this was a 37-year-old lady with a pleural fluid, and it, so you can see these three-dimensional clusters of these tumor cells. Immediately a cell block was made. You can see the glands, you can see the tumor cells. Just two markers, TTF1, which is positive in the lung cancer, and CK7. Now TTF1 is also positive in thyroid, but obviously this is the lung cancer. And then when they did the radiology, they found a lung mass. This was a 57-year-old lady with a positive ascitic fluid. Immediately make a cell block, and you can do anything on that cell block. And on that you can see CA125 is positive, CK7 is positive. So this is a metastatic ovarian carcinoma. So over this period of 3.5 years, we have seen about 7,000 cytology samples, and about 10% of them were subjected to these ancillary studies, and all kind of LBC added, EUS added, IHC added, molecular added. Everything helps you to just go better and better. So how it helps, you can see the percentage of positivity. For example, with urine, you can see that the number is just double. So we had 2% positive when we were using conventional, 4% positive, BAL 3%, 9%, just triple. This is US, again, I'll not go into it. Very important is the theranostic application, which I'll end it. The whole talk today is about targeted therapy. So those days are gone. Today, nobody wants to give chemotherapy if they can give a targeted therapy. And that is why it becomes so important at that ancillary level in a cytology sample to tell them what it is. So earlier, it used to be nitrogen mustard, then it became antifolates, by the way, because of a pathologist. And then there came the era of combination chemotherapy, where they said, like TB, if you combine XYZ drugs, give it for this much time, the patient will become all right. But then now, today, it's not like that. So there was a period of quiet in which all these mechanisms were further elucidated. And today, you and I are living in the era of targeted therapy. So today, there is a target available for most of the cancers, at least most of the common cancers. So whether it's your tyrosine kinase inhibitors, whether it's your ER, PR, tamoxifen, HER2, rituximab, there are a lot of targeted therapy available. So that becomes very important. So we use this for a lot of our cases. So we do ALK, EGFR, HER2, ER, PR, everything. So you can see this is a cell block, pleural fluid. This is a metastatic carcinoma in a breast primary, beautifully positive for ER. Does this ER positivity look anything less than a tissue positivity? No. It's just amazingly, strong reaction. This is a pleural fluid, again, in a metastatic breast carcinoma. This was positive for HER2. So you can do even FISH on a cell block. This is an ALK positive in a pericardial fluid. So this is a pericardial fluid which is positive for mets from a lung primary, and very few cells that you can see. This is the fluid, hardly any cells. This is a cell block preparation, and you can see beautiful ALK positivity. This was the EGFR in another pleural fluid, metastatic adenoCA, lung primary, and we've done about 13 EGFRs in pleural fluid, out of which 3 were positive. Most common, it's an exon 19 or exon 21. So a few basic points for everyday use. Yes, fixation. We've heard this in general about cytology at a primary, lab level when the case has come. So yes, people used to use dry fixatives earlier, spray fixatives earlier, which are good for transport and all. But we have to always remember that there's carbo wax on them, which should be removed before you stain. Because if you don't tell your technician to remove that carbo wax, you will always see a hazy picture. The nuclear details will never be clear, and there is a chance to make a mistake. So obviously, it's best to go with the preferred wet fixatives, out of which you can use any of these. Is ethanol, methanol, combination of ether and ethanol. Then, of course, cell block. Now, I see a lot of articles on all kind of, in Muti Madam's language, Gondas reports on cell block. There is agar, there's clot, there's this, there's that. Nothing is required. Neutral buffered formalin works as well as anything else, and you can do any molecular, any IHC, does not hamper anything. Immunocytochemistry, you can do, earlier people used to use chilled acetone, methanol, now it's shifting over to ethanol and the LBC preparatives. Staining, yes, use the common MGG, PAP and HNE. So that's all. But the key points to remember is that you must have a good and a well-preserved material. You must validate whatever you are doing, constantly. Am I done it right? Review it, get this test done. If somebody takes a case for second opinion, call him back and say, what kind of report did you get? Is it the same? If it's not the same, go back, look at the slide, see where one has made a mistake. Control the cases morphologically. All ancillary tests, the control is at morphology level. There is no other control. All those are technical controls, but basically it has to be controlled morphologically. And in patients with advanced cancer, only a small biopsy or an FNAC sample will be the only way to go ahead. They cannot do anything else. And cytologists and technologists must meet this challenge by doing it well. So I think pathologists are going to play a very different role now with cytology. We must participate in developing and implementing these tests which aim at personalized medicine. We should recommend these tests to patients and clinicians when required, and we must share this with our colleagues and community-based practice, as is the forum today. So it's a very good time to be in the pathology sector, and I think it's really just going to get better and better. Any questions? Okay, so if there are no questions, I think we have Kane Madam's talk now. I don't think she needs any introduction. So, ma'am, I welcome you.
You can also ask questions in the coffee break. Good morning, everybody. Can you have, now after her talk on molecular techniques, I'm going to take you to the very simple talk. I'm going to take you to the mundane thing, thyroid FNAC. I'm sure all of you must be seeing, at least not, if not per day, per week, few cases of thyroid. But I'm not going to tell you about the entire spectrum of thyroid FNAC. I'm going to focus on what is indeterminates. Limitations of the main limitation of thyroid FNAC, as you know, or inadequate. That is category 1. How many of you are using Bethesda system for reporting? Some of you I can see, but it's time that we should shift to Bethesda system of reporting and have a uniform or standard reporting system. You will see some of the advantages as I go by. So my talk is going to be restricted to indeterminate, which ranges from 15 to 25%, which includes category 3 and category 4, and even category 5, that is suspicious for malignancy. Now, if you can see, most of these are follicular pattern lesion. That is the biggest challenge as far as thyroid FNAC is concerned. Now, this is what is the Bethesda system. I'm not going into detail with that. So, basically, benign is the green category, which nothing active but only clinical follow-up. Whereas these two are definitely indeterminate, atypical follicular lesion of undetermined significance, wherein different treatment is to be given. Once it is follicular neoplasm, some sort of surgery is necessary. You cannot just restrict to repeat FNA. Whereas these are the red, like suspicious for malignancy and malignant. In some of the works or studies, even suspicious for malignancy is included as indeterminate. But I don't agree with it. Once it is suspect malignancy, it is almost like HSIL. The treatment is necessary. And most often than not, it will be malignant. So I'm going to restrict to this particular area, that is AUS and this. So how do you reduce the indeterminate in thyroid FNAC? Well, there are pre-analytical, analytical, and post-analytical. I will mainly touch upon this, that what are the different methods which you can reduce the indeterminates for pre-analytical as well as the analytical aspects. Okay, so why the low yield of cells is there, which is a very common issue. All of you know there are some operator risk as well as there are inherent factors. The small nodules, calcification or sclerosis within the nodule, some of the tumors can show sclerosis, posteriorly situated lesion with lot of colloid material, cystic lesions, and even thyroiditis will have a very few follicular cells. Whereas traditionally these operator skills are basically due to difficulties in localization of the nodule, number of passes which are given, and the most important is dwell time. In thyroid, you should always look for minimal dwell time. More you go and dig the thyroid tissue, more blood you draw and less. So actually the success of aspiration or non-aspiration but fine needle lies in the minimum dwell time. So also the gauge of the needle should not be very thick. It has to be 24, 25, 26 as needed. And of course for thyroid, it is a non-aspiration technique which is done, which is better than the aspiration technique which we follow for other things. But you must remember that thyroid thyroid FNA is a operator dependent. This is particularly when the radiologists are doing the thyroid aspiration under imaging guidance. These days, majority of the thyroid FNA are done by the radiologists under USG guidance, whether it is palpable or not. And this is essentially to have a proper localization of the nodule. So nodule may be cystic, it may be necrotic, or sometimes there may be multiple nodules to select also which nodules to be aspirated. That is the better technique. Now all of us have seen this kind of aspirates, you know, on our table. It may be cystic with thin colloid, macrophages, but more important is this. Daily I see at least one FNA wherein it is quite cellular, as you can see here, but all the cells are embedded in the blood clot, which results in the poor visibility. You see the cells, but you don't see the nuclei. And this should be avoided, and we'll come to little later. Scan cellularity and also degenerative cells, and in which case you may have to repeat it, but when are you repeating the thyroid FNA, it is better to have under image guidance. So these are some of the reasons why there is an unsatisfactory yield. All of us know this. This is the better way, a solid nodule, and you are going into it. But remember, it cannot be only one pass. You have to sample the different areas. And why will come it to later. Sometimes it goes tangentially, sometimes it goes in the cystic necrotic center. Sometimes the main lesion is, you know, at the periphery, which is small, and there is a bigger central lesion which may be benign. So it is ultrasonologist, you should locate it and you should sample this as well as this, but should not leave this particular portion out. So sometimes it happens that patient has cancer, and what you get in the FNA is the benign lesion, and the associated node can show metastatic cells. And sometimes there is a solid lesion, but it is too much sclerotic. We have come across such situations where even if you are within the lesion, you may not get the proper cells, and which is known. So all these things can be avoided by doing on-site cytology. And that point will be covered later, will be partly covered here. So now I'll tell you some of the pre-analytical tests to reduce the indeterminate as much as possible. We have been using this stylet to, you know, avoid or minimize the hemorrhage, by which the cells will not get tapped within the hemorrhage. And one should try that using the stylet, particularly for thyroid FNA. Now when we analyzed our thyroid FNAC, we thought that our indeterminates or particularly inadequates was a bit high. So these were the measures which we took, and by which it really came down. All aspirations were shifted from non-guided to guided. Initially residents used to do aspiration, and now majority of our thyroid FNA is guided aspiration. For majority of these guided aspiration, we do on-site adequacy testing. Of course, this involves orientation of lectures to pathology as well as radiology residents, also appraisal of cytotechnicians to avoid air drying and crushing artifact. As previous speakers have said, the success of interpretation or giving highest result always depends on the technique. Not only the cell yield, but the smear should be well made, well fixed and well stained. Unless that your raw material is good, your final product can never be a good. So this is also important all the time. In addition, use of stylet, I just mentioned, minimal dwell time is important, immediate fixation. Of course, in case of cystic lesion, you should reaspirate if there is any residual solid mass. Here also, ultrasonography becomes important, and always keep extra smears, extra unstained smears for ancillary test. So what exactly means by the good diagnostic yield? It's not only presence of viable lesional cells in adequate quantity, that is 6 groups of 10 cells each, And adequate cellularity after Bethesda is not a subjective. There are definite criteria laid down as this, so that, if you say the non-representative smear from different pathologists, the cellularity will vary. Some of the smears will really be non-cellular or less cellular, whereas in some cases you will have a good cellularity, but the visibility is poor, and that's why they are labeled as acellular or less cellular. Actually, they are non-representative or unsatisfactory. More than that, they are unsatisfactory. So you should always see that there is a minimal obscuring elements like blood, inflammatory smear. Fixation should be good, your smearing technique should be good, and these are also important on saying that the cell yield is good. So it is not about only cellularity, but always type of cell. So this is how on-site adequacy testing is done, which can be done by pathologists, also by cytotechnologists. You fix the smears in ether alcohol for 30 seconds, stain with toluidine blue, 10 seconds, mount in glycerin. Check the cellularity in radiology OPD under microscope. In our center, cytotechnologists are doing that. If it is adequate, you can restain the same smear with PAP for final diagnosis. If you find that the cellularity is inadequate, then there and there only it can be re-aspirated, same setting under the guidance. So you don't have to wait till final PAP stain is done. And at the same time, if you find that it is a little unusual case, you can also collect extra smears for ancillary techniques. And the cost and time is very little there. Cost is just 5 rupees, and the time taken for on-site adequacy is 1 minute. So it is easily doable by everybody and anywhere. It need not be a very, big oncology center. Shall I go back? So what are the Yeah, so this is what we actually want to see. Yeah, adequate smear that is very good cell yield, very well fixed, and you can make diagnosis even on this, which is not even a 1 high power field. Adequate representative smear, and what is important there, sampling from different parts in the nodule under imaging, and you know that you have got representative material to really offer a pinpoint diagnosis on it. Now in thyroid, having a good technique and Gulser is one part. But does that obviate the diagnostic challenges? No. Even with that, diagnostic challenges are galore. This is mainly in thyroid because of overlapping cytologic diagnosis. I'm going forwards. This is essentially because of overlapping cytologic features between neoplastic, non-neoplastic lesions, which happens mainly in follicular pattern, but also in other pattern lesions like Hurdle cell lesions, clear cell lesions, etc., spindle cell lesion. There are overlapping features between neoplasm also, including papillary thyroid carcinoma, medullary carcinoma, even an insular carcinoma. Then quite often you may get coexistence of neoplastic and non-neoplastic lesions, and the needle may pick up only one area or few cells from PTC, few cells of Hashimoto's thyroiditis, and that may be the source of error on degenerative changes which can mimic malignancy, so on and so forth. And this has to be overcome through awareness and also with experience and expertise. So now we come to AUS. All of you might have given this diagnosis, which is not given very often, but we must exactly know that when we call AUS. It is Bethesda category 3. It is a heterogeneous entity. Remember, this is not a lesion. This is not a diagnosis. Okay, this is a category in Bethesda, and it should not be used as a waste paper basket for indeterminates. Means you are seeing cells under microscope, but you don't know what to call, so don't call it AUS. So there are definite criteria. You see cellular atypia. It is neither sufficient as follicular neoplasia or suspicious for malignancy, nor the atypia can be dismissed as benign follicular lesion. So in fact, it is a atypia of undetermined significance. You do not know whether it is benign, you do not know it's a malignant. It is a gray zone in between. In other words, in benign lesions also, you will get certain atypia, but you can identify it is a little atypia associated with degeneration or reactive changes, and you are putting it as benign. There is a atypia which may be qualifiable as follicular neoplasia, so you put it as FN. But when you do not know whether it is benign or malignant, you call it AUS. It can be in the follicular cells when you call FLUS, or atypia can be other cells when you call AUS. But why it is to be separated out from benign? Previously, what used to happen when you never use the Bethesda system? Where would this AUS go? It would either go as benign or it would go as in FN. But remember, there is a small but definite risk of malignancy, ranges from 5 to 15% when you call AUS. So in AUS also you can have malignancies parallel to your gynae pap smear also. And they account for 3 to 6% of thyroid FNAC report, but it should be less than 7% of all FNA. When you are doing Bethesda reporting, it should not go beyond 7%. In our center, it is 3% and around. So it is parallel to ASCUS and AGC NOS. ASCUS, no, it is parallel to ASC and AGC NOS. So you don't know what is its significance. So when do you label any atypia which cannot be further qualified? So now I am giving examples. You see some nucleomegaly, somewhere irregularity of nuclear membrane, there is a nuclear pleomorphism, even occasional nuclear groups, but there is no corresponding architectural atypia. There is a colloid in the background, so you cannot label straight as suspect malignancy or malignancy. Sometimes you will see architectural atypia in terms it is very cellular FNA, large sheets, there may be microfollicles, predominant pattern, somewhere there will be nuclear crowding, focal loss of polarity, but cytological atypia will be minimum. Sometimes you may see some cytologic and some architectural atypia, but there may be preparation artifact, bloody thick smear, there will be crushing artifact, or there will be abundant colloids. So when your comfort zone is not there, in that case, you cannot call something as malignant, and this is AUS is the category. But remember, the number of cases which has been labeled as AUS is inversely proportional to the cytopathologist's experience. I reiterate, because you don't know something, don't put it into AUS. Try to categorize them as per Bethesda guidelines, and you will be able to minimize your AUS categories. So what do you do? What is the significance? Once it is given as AUS, it means repeat guided FNAC. As I mentioned, AUS is no diagnosis. You have to come to diagnosis. It is put as diagnostic category 3. So what happens with repeat guided FNA? In 80% of cases, the more definitive diagnosis or will be given. Now it may be benign, it may be FN, that is follicular neoplasia, or it may be suspicious or malignant. What happens when you give a diagnosis of benign, then nil active management is necessary. So you take it out. When you give as follicular neoplasia, then either you have to do hemithyroidectomy, if possible with frozen section, and then decide whether you are going to total thyroidectomy or let it be hemithyroidectomy. But when it is suspicious to malignant, usually followed by total thyroidectomy, if possible frozen section in this category to confirm your diagnosis of malignancy. Okay? Then what happens? In 20% cases, it will still remain as AUS for whatever reason. See, AUS is because of two things. If inadequate cellularity or improper fixation, that you can improve by repeat guided FNA. You know what the fault is. But sometimes you see the cells, they are adequate, they are well preserved, but still you don't know where to put. So in that case, the repeat diagnosis also may be AUS. And here comes then the importance of molecular studies to further classify. You do molecular studies and then you can, stratify them into benign or malignant. If you do not have, when you repeat it, AUS diagnosis, then you have to again follow with hemithyroidectomy. That means you have to reach to a diagnosis. In gynae, there is a colposcopy and biopsy. Here, there is nothing like a thyroid biopsy unless it is a huge mass like anaplastic carcinoma or non-Hodgkin's lymphoma primary. Usually it is hemithyroidectomy and frozen section, and depending upon that diagnosis, you will decide further whether total thyroidectomy is to be done. So what does it mean? That once you give a diagnosis or label as AUS, it necessitates active management. You cannot leave that patient, and therefore it is an important diagnosis. Whereas when you see benign, you can leave the patient with, of course, USG follow-up, nil active necessary. So now we come to the molecular studies. FNA provides good material for molecular studies. It has been covered by Kirti. There are many genes which can be studied in NGS technique, and it is becoming popular abroad for thyroid FNAC. The important genes for papillary thyroid carcinoma, of course, are BRAF and RED PTC, and even a RAS gene for FVPC. These are also, there are the genes also for follicular thyroid carcinoma, that is PAX-7, PPR gamma, and RAS. But I am mainly talking about PTC, which is the most common diagnosis in FNAC or otherwise. Now the importance of these genetic alterations are mutually exclusive. They are not overlapping. So the ones which have BRAF won't have red PTC and vice versa. They can be used in case of indeterminate FNAC to reduce this indetermination, and you can give up, if positive, you can call it cancer. That is their advantage. So they have a great positive predictive value. Positivity means cancer, but negativity doesn't rule, which holds true everywhere. And there is a high concordance rate of positivity of BRAF and then histology showing papillary thyroid cancer if these are the genes involved. So molecular diagnostics is coming in a big way. The Nikiforov is the main person behind this. He's in Pittsburgh University. There are several authors related to molecular diagnostics of thyroid tumors where they are using it on thyroid FNAC. One negative thyroid FNAC, clinical or ultrasonologic suspicion, immediately FNAC is repeated, molecular studies are done. If positive, they are doing total thyroidectomy based on positive molecular studies, and they do not have any false positive result in that. So that shows the importance of molecular diagnostic. This is his paper, and in conclusion he says the most common molecular alteration is BRAF and RAS point mutation. So also red PTC, PAX-7, PPR rearrangements. These non-overlapping genetic alterations are found in 70% of papillary and follicular thyroid carcinoma. You know which are the main cancers, differentiated cancer in thyroid. This can be detected in surgically resected samples, so also FNAC. The diagnostic role of BRAF mutation has been studied most extensively and demonstrated a significant diagnostic utility with all these genetic alteration on thyroid FNAC samples, particularly when initial report is indeterminate. So use of these and other emerging molecular markers is expected to improve significantly the accuracy of cancer diagnosis thyroid nodules and allow more individualized surgical and post-surgical management of patients with thyroid cancer based on these studies. So this is the future, and I'm sure even in India, this is going to be standard of care within a decade or so. Now we come to our data. This is a 1-year data for thyroid FNAC. Look at our indeterminates. Category 3, 33, 2.89. Category 4, FN, is 5.70%. Okay? And this is the graph showing, of course, benign is the maximum. Since ours is a cancer center, malignant is also high, suspect malignancy and malignant, whereas in other hospital, these figures would be definitely different. So together, it accounts for only 8.59%, 3 and category 4. Okay, now this is also, this is what I wanted to show. I don't have the current figure. This was actually data of 2013. Now we thought that this is a little high, and then we employed those measures, and then these things in 2014, all these numbers changed. The important one, this went down to 6%. The benign went little bit down, whereas these two went down. Indeterminates was less. Suspect malignancy went down because here we were not strictly using the Bethesda category. This is on review. Some cases it was used, some cases it was not used. Whereas in 2014, all of us started applying Bethesda category. And with that, this is what we could sort out the cases in a proper labels. And with that, what reduced was suspect malignancy, which obviously became malignancy. It reduced the indeterminates, and it also reduced this. It is, of course, not only because of applying Bethesda, also because of what measures we took to increase our sensitivity and cell yield. Now, what is this AUS? It is really a gray zone. Goiter is clearly benign. Follicular neoplasm or malignancy is clearly malignant. But in between is AUS, where you don't know. And this is going to remain, but you have to reduce it as far as possible. Look at these possibilities. Now, these are histopathology diagnosis. Now, comparable diagnosis. You have benign FN and suspect malignancy. But let me tell you, all these conditions, sometime or the other, on FNAC are labeled as AUS because of the various reasons. Okay? because of poor cell yield, poor observation. It can be interpretative error also. So all sorts of errors occur in thyroid FNAC. Sampling, technical, interpretative. In interpretative, it may be lack of awareness, or along with it may be other technical errors, combination of the errors. So now I'll give you some examples. This was 39 female, FNA from solitary thyroid nodule. It was called AUS. It was cellular FNA. Okay, and there were a good number of microfollicles were seen in this, and there was not much of nuclear overlapping, but nuclear crowding and focal overlapping was there, as you can see here. So what do you think this could be? The appearance was same in different. Now you can see it is actually the same area. I had not included this particular area. What is it showing? See these cells and these cells? It is actually showing a nuclear variation. Okay? So in that main sheet, the nuclei are more or less of same size, except some of the occasional nucleus which is looking big. But see this closely situated area, and here also. This is little bit hurdle cell change is coming in, and there is a nuclear variation. The colloid is not there in the background all the time. If you see colloid, it is very helpful. But sometimes in the benign cases also, colloid may not be seen. Now look at these. These look fairly benign, as you can see here. Anybody has a doubt of malignancy? But look at on the high power, you could see a nuclear groove. This was only in one area that we could see nuclear groove. So the question is, what do you give then? Do you call it benign? Do you call it malignant? So overall, we put it as AUS for the reason that it was cellular, but there was no colloid. These things were in the sheets with microfollicles. Somewhere there were nuclear crowding, and there were occasional groove. So we couldn't really put it into suspect malignancy or malignancy. And top of that, there was even a nuclear variation. Nuclear variation in thyroid goes towards benign and not malignancy. You must understand that thyroid is little different from the other organs. In other organs, diagnosis of cancer is easy, but because the cancer is never differentiated. In thyroid, the common cancer is always very differentiated with nuclear changes almost of grade 1. You can diagnose adenocarcinoma in biopsy very easily because it is hardly ever grade 1. It's always either moderately or poorly differentiated. But thyroid, you are constantly facing a grade 1 type of thyroid cancer with overlapping features with benign. So it is always a problem. It's a common diagnostic challenge. So with some features of nuclear, some features of nuclear hole or nuclear groove doesn't make it malignancy. And you have to, really judge what are the other features favoring malignancy. So don't go by just a groove or this. This doesn't really mean that this is a papillary thyroid carcinoma. And this was the histology, which was nodular goiter with some papillary hyperplasia here and there. So this is what happens. AUS on one hand can include just a hyperplastic goiter, and it may include other lesions also. Now this is just to show you that, see the difference. This is one case I showed you, and this is other case. So you have to look for these features to call it malignancy or suspect malignancy. See the nucleomegaly, see the chromatin, pale, powdery chromatin. The micronucleoli, which you quite often see in the papillary thyroid carcinoma. Now where is the groove and hole? Anybody can detect. But if I see, good number of follicles or clusters like this, I will call papillary thyroid carcinoma, without even nuclear grooves and holes. Does that mean grooves, holes are not necessary? It is not. It's always a constellation of features. But for me, what is more important is nucleomegaly, nuclear overlapping, and pale chromatin, rather than nuclear grooves and holes. Okay, and the typical, now this we go to another case. This was called as follicular neoplasia. Can you tell whether it is benign or malignant? See how cellular it is. Unless it is cellular, of course, you don't call follicular neoplasia. Cellular, monotonous, lack of colloid, repetitive microfollicles. So these are the basic features for FN. So I think this, fulfills FN. Anybody has any doubt? I have told you many of these. But see what it turned out to be. Adenomatoid goiter. Why it happened? One thing I didn't mention was raised nucleocytoplasmic ratio. That was not there. If we go back, everything was there. Okay? Nuclear crowding, microfollicles, cellularity, monotony, lack of colloid. But raised nucleocytoplasmic, so for neoplasia, you must have raised nucleocyte. That is how you distinguish it from benign. Okay? You won't have nucleoli, you may not have a chromatin clumping, but you should have a raised nucleocytoplasmic ratio. So what happens when needle goes only in this adenomatoid area? You may get, you may call it follicular neoplasia. But look at this. This is the same lesion having other areas which look like a goiter. So if needle doesn't go in this area, you may end up calling FN. If needle also goes in this area, you get colloid and you tend to call it, benign or category 2. So this is what happened. Geographical myths are known to occur in the thyroid nodules, and this can be resolved by multiple needle passes in different parts of nodule. So one important is minimal dwell time, and second important feature is multiple passes needle from different parts of nodule. So herein, if the nodule is benign, you will pick up different areas and you will be able to diagnose. And there the rule of thumb rule is variation is the pointer towards benignacy, and monotonous nature, lack of variation points toward malignancy as far as differentiated thyroid cancer. These rules will not apply to higher grade thyroid cancer, that is poorly differentiated and anaplastic thyroid carcinoma. So, okay, now these are the other two cases, some more cases of FN. Both of them were called FN. Actually, these two together is little becoming difficult for me to adjust. Okay, so different cases of FN. See this? This was the case I showed you, of course, and this is another case. Can you tell me what is this case? Means what it would turn out to be. So this turned out to be adenomatoid goiter, okay, and this turned out to be FVPC. Now the typical vacant nuclei that you associate with this is essentially FFPE artifact seen in the paraffin section, and it will never be seen in FNAC. So in FNAC, don't try to look for vacant nuclei and whatever. It is always pale powdery chromatin. So if you understand the typical nuclei of FVPC, you will be able to diagnose even if the cellularity is less, and even if you don't see nuclear grooves. Why I mention nuclear grooves and holes? In FVPC, you may see few nuclear grooves as compared to conventional papillary thyroid carcinoma. So don't wait till you see grooves for diagnosis. Of course, it is always good to have grooves to diagnose any papillary thyroid carcinoma, but just remember that grooves don't make papillary carcinoma. So these are the cases of FN, which on cytology were called FN but turned out differently. So this is discordant. For FN, remember FVPC is discordant. FN includes follicular adenoma and follicular carcinoma. We wrongly include FVPC and adenomatoid goiter in FN. But actually FN includes follicular adenoma and follicular thyroid carcinoma. So, okay, so can you distinguish AUS and FN which are very close to each other? Yes, theoretically you should be able to distinguish AUS category 3 from FN. So see, what you observe here is the cellularity can be there in both. Here it is cohesive, here it is three-dimensional. But more than that, whatever changes you see are focal in AUS and they are diffuse, prominent or monotonous in FN. Because it is neoplasia, because this is more often benign. So what happens, microfollicles also will not be repetitive as you see in FN. You will see a mixture of follicular and Hurdle cells that contributes to the variation, here monotonous cell population. Nuclear crowding will be seen but focal, not prominent. Nuclear atypia will also be focal, by that I mean nucleomegaly also. Here it is diffuse nuclear atypia. Polarity is maintained in a benign lesion. Here it will be loss of polarity. And here is the importance of sampling from different areas. So in some areas you will see this and you will tend to call FN. But if you sample different area, they will be typically benign and you will be able to diagnose your AUS. So lot depends on technique in thyroid FNAC like others also. Now this is another case of FN, which was called FN in this. This is not the previous case, and it turned out to be follicular thyroid carcinoma. So this is truly a concordant lesion for FN, whereas previously I showed you all the discordant FN. So FTC is a concordant FN, so also follicular adenoma. Now what we did a breakup of these categories, indeterminate 3 and 4, wherever histology was available, which was only available in 22% in AUS and 34 in SFN, that is suspect follicular neoplasia. Hurdle cell neoplasia are also included in it. Now see our results. In AUS, 38.5% turned out to be benign and 61.5 malignant, whereas in the category of FN, 10% were only benign and 90% were malignant. Now when you break up the malignancy, in AUS group, PTC was seen in 30.8, FVPC 15.4. That is together 46% were PTC and only 7.7% were FTC. Whereas in FN group, 70% were PTC, 35% conventional, 35% FVPC. So in both sides, it is the PTC which is dominated or which is missed on AUS and FN. I mentioned before, FN should not include FVPC, but because FVPC nuclear features are subtle, they depend a lot on your technique, they are always missed or underdiagnosed, and all these PTC cases come up in FN. So improve your technique and you will have a better nuclear visibility. So these are the common diagnostic errors, but more than this is very common. FVPC is underdiagnosed as adenomatoid goiter. And I just explained, so this is a common cause of false negative, whereas common cause of false positive is adenomatoid goiter is overdiagnosed, and also Hashimoto's thyroiditis, which is another biggest pitfall because of associated nuclear atypia, which can resemble papillary thyroid carcinoma. So in your FNAC, always look for lymphocytes in the background and a Hurdle cell change, and moment you see any one of the two, try to downgrade the lesion and not call it FN or suspect malignancy. So then what are the criteria for cytologic diagnosis of papillary carcinoma? All of you know, so I am not going to go in detail. See, majority of them are nuclear. Nuclei, nuclear membrane, powdery chromatin, nucleoli, groove and inclusion. So the patterns or the background doesn't make much difference. They of course offer a diagnostic clues, but they are not really different, are essentially nuclear. And to appreciate the nuclear criteria, your again technique has to be good. And that is the main reason why they are missed, and not called FVPC and call even AUS. So do not depend only on intranuclear grooves and pseudo-inclusions. This is my message all the time, because there are various other lesions where you see nuclear grooves and inclusions. Because this is essentially for PGs. Whenever you ask how do you diagnose papillary thyroid carcinoma, the answer comes grooves and grooves and holes, and I feel they are overemphasized features. If you see, well and good, 70% of FVC may show occasional nuclear grooves and holes. So you cannot, not diagnose FVPC because they are occasional. It is always the constellation of features which is important. So papilla plus grooves or holes doesn't make it PTC. So also follicles plus grooves and macrophages and colloid doesn't make it goiter. You can have a cystic papillary carcinoma and you can have a FVPC, which can be mistaken. So please go for the constellation of features to make the diagnosis. So 30 years ago when I did MD, the follicular pattern lesions included basically adenoma and carcinoma, not realizing there are follicular adenomas are very few. What used to happen is even an adenomatoid goiter was actually called follicular adenoma. Adenomatoid goiter with some amount of fibrosis around, it may not be complete, was labeled then. Now the scenario is changed. When you talk about follicular pattern lesions, see whether they are benign or malignant. If they are malignant, majority are going to be follicular variant of papillary thyroid carcinoma. These I am telling you about the thyroid nodules, because majority of the thyroid nodules are small. They are detected by USG and they are not really clinically apparent or symptomatic. So this incidence is very high. Follicular thyroid carcinoma as such is very low in our setting. PTC incidence is also rising. And when you talk about follicular lesion, it is basically adenomatoid goiter and not, or sometimes even a thyroiditis, which can show microfollicular pattern also, and very rarely follicular adenoma. So these two lesions are important as far as FNAC is concerned, particularly incidental lesions detected on thyroid USG. So there are several factors responsible for false negative cases. I have just covered some of them. There are some are interpretative, some are technical, and that's why I keep on mentioning you should improve technique and you should improve your interpretation to lessen the false negative as well as false positive. And if your smear preparation is suboptimal, even though the cells are there, it may lead to false negative diagnosis. So also there are reasons for false positive, and we should try to avoid all kinds of artifacts, drying, crushing, so on and so forth, to have a better visibility. So what are one of the methods to reduce indeterminate FNAC is also to switch on to LBC, which was covered already. Again, just to highlight, it reduces the rate of false negative or inadequates. It helps in giving quicker diagnosis because whatever cells you want to see are front of them. They are not diluted by colloid or lymphocytes or other things. It improves identification of lesional cells, hence pickup of malignancy is better. And of course, there is always standby material for ancillary techniques, which can be ICC or even molecular pathology. Smears are always thin, even reproducible. They are not operator dependent. Whereas in conventional, all of us know a lot depends on how it is fixed, how it is smeared. These are the scenarios where your ICC may be important. As she mentioned, in every case it is not. You must know what is problem in front of you and then apply it judiciously. Now this is said HbME1 CK19 positivity means FVPC, and you can distinguish it from adenomatoid goiter, but we are not doing it routinely. I am doing it routinely mainly for this. You know it is cancer, you can see it, but you cannot distinguish whether it is MTC, PTC and PDTC, and it does happen. You don't see amyloid and you are wondering. It is very easy to apply chromogranin, calcitonin and CD56 if these two are positive. It is definitely MTC, and negative, now here negative may rule out MTC because these two are positive in almost 100% of cases. So negativity helps you to rule out MTC. So also you have a spindle cell lesion and you are wondering whether it is spindle cell MTC, spindle cell anaplastic thyroid carcinoma, it is useful. So there are definite situations where you can judiciously use immunocytochemistry on the smears, which can be destained or unstained, and you can come to the conclusion. Of course, teamwork is necessary. You cannot do anything without the teamwork, and in this team, you have clinicians, radiologists, cytotechnologists, and thus it really helps to improve the diagnostic accuracy. So to conclude, on-site adequacy testing as well as the correct technique, which includes many things, result in good cell yield, and it is really a key to diagnosis. Follicular pattern lesions offer diagnostic challenge. Whatever you do, these challenges remain in thyroid, and that does result in false positive or false negative cases. So you have to concentrate on finer details, and it is always the constellation of nuclear features which is important rather than the patterns or background. Number of AUS cases are inversely proportional to cytopathologist experience, and once you give a label of AUS and FN, they should be followed up stringently. Active management is necessary, cannot be left alone. Now remember, PTC is the most common malignancy, otherwise also, and definitely so in the thyroid FNAC, and therefore it can be, and with inadequate technique, inadequate material, it can be mislabeled as category 3 and 4. ICC is an ancillary technique which needs to be used judiciously on FNAC. Molecular techniques are already being covered. They have a very good positive predictive value. And don't hesitate to take expert opinion whenever needed to reach the accurate diagnosis, because in thyroid FNAC it is necessary. So have patience and use it judiciously. I did not cover, of course, correlation with clinical and ultrasound findings, which is necessary. All of you must be doing in a difficult case. That also adds value to your interpretative skills. Thank you for patient listening. And you're most welcome to ask any questions if you have.
Will molecular study solve all problems of AUS? Are they false negative? You said false positive, but what about false negative?
Yeah, of course, if they are positive, but then you'll have to cover both for PTC, follicular thyroid carcinoma, if required, MTC. So you have to use different genetic markers, and if they are positive, it means cancer. That is what I showed you clearly. There is a very high positive predictive value. If negative, they will not rule out cancer. So that is the future that will come up here. That
Will it replace cytology?
no, it won't replace cytology.
Molecule is an adjunct to morphology.
Adjunct, always to adjunct. Cytology will remain as a basic thing. First of all, you should have cells also. Because, good number of benign can be easily separated out. I have not touched upon it. See, the main purpose of thyroid FNS is to weed out benign, which is obviously benign. And then all those which are non-benign, you should apply. And you cannot, your comfort zone is low. You are not going to call it malignancy. So that's why suspicious of malignancy is also included in indeterminate to apply this molecular test. Positive is very good. And there are a lot of articles coming now on molecular PAN. Any other questions? Otherwise, we are ready for coffee. Yes, it's a break.
Make it short, 10 minutes short coffee break because we are running.
Yeah, running behind the schedule.
So let's meet back in 10 minutes, please, everybody.
But please, any other question you can ask me. I mean, you can come to me and ask personally.